Okay, so starting off, I have the infographic. I believe this was also in your PowerPoint. Don't have to memorize the whole thing like this. This is just there to provide a little bit of context and kind of show the progression of everything, which I also kind of wrote down here. So sepsis is essentially an over-exaggerated response to infection. Your body just has a systemic-wide immune response. That's what SIRS is, which leads to the release of a whole bunch of stuff. Overall, you have these things happening. You have vasodilation, you have capillary leakage leading to third spacing, you have clotting cascade. And I also provided a list of some of the consequences that kind of come along with that. So, for example, you're going to have a decrease in perfusion, and that decrease in perfusion is going to lead to MOTS because less perfusion due to clotting. Um, if the organs aren't getting enough perfusion, then they start dying out. Because you have that clotting cascade, patients could develop DIC, so use up all their clotting factors, have a bunch of mini clots, and then bleed out. The patient can have issues with their immune system that we'll talk about later due to the corticosteroid release when we talked about Cushing's disease, I think last semester, I think. We talked about how Cushing's disease, one of the things that happens is weaker immune system and hyperglycemia. So because of this high amount of corticosteroid, that's essentially the same concept. You have decreased immune system and hyperglycemia, similar to when you actually take a steroid as a medication. And another consequence is dysrhythmias because your body tries to compensate for the vasodilation with catecholamines, which are your hormones like your norepinephrine, your dopamine, your epinephrine, which we know the majority of those have an impact on your heart rate as well as your blood pressure. But because of the impact that they have on your heart overall, they can cause dysrhythmia. So someone that's having sepsis can develop an MI or a lethal dysrhythmia or just a dysrhythmia because of their condition, their body over exaggerating and then compensating in a way that leads to other outcomes, other consequences. So I developed my own list for consequences of sepsis, and I have it down as like 5 C's. So kind of like Professor Robbins's like SAFE SAVE acronym. I kind of this one we kind of finagled this one so it actually fits with the C's, but everything else is actually genuinely with a C. So that's how I remember it, the 5 C's. So catastrophic vasodilation. So there's all that vasodilation can lead to a decreased MAP and MODS, like we talked about before. There's capillary leakage. So again, we said third spacing. Overall, this is going to lead to hypotension. We said corticosteroid, the consequence being the weakened immune system and hyperglycemia. Catecholamine, so again, norepinephrine, epinephrine, dopamine. That compensation can lead to dysrhythmias because these can affect the blood pressure and the heart rate, have an impact on the heart. And then the last C for clotting cascade, which is how you remember that this condition can lead to DIC. So sepsis can lead to shock, septic shock, can lead to dysrhythmias, can lead to DIC, can lead to MI, stuff like that. Okay. So hopefully the having this actually helps you guys in remembering it. But a question for you guys is, what are the main causes of sepsis in terms of infections? Which type of infections cause sepsis? Most likely cause sepsis. Okay, you have respiratory, So yeah, like a pneumonia is like an example of one. Okay. Skin infection. So we're gonna kind of do first is respiratory, GIGU, UTI. Yeah, so GIGU would be your second most common. So, uh, and we mentioned skin. So samples of GIGU infection, UTI, H. pylori, which is the one that can cause your ulcer, peptic ulcer disease. And then the third most common is skin infection, such as cellulitis, type of infections. But there's also different sources, but these are just the most common causes of sepsis. So when you see like an infection that originates from these, you should be kind of consider that a sepsis a little bit more, kind of think of it from that lens. Any questions on what we talked about so far? So basically, so far, all we've really said is what are the main causes and a way to remember the consequences and kind of what happens in sepsis. Okay. So something that you guys should 100% know is your search criteria for this test. So what is the search criteria used for? To identify possible sepsis? Is this your assessment of shock, of septic shock, or at what point does it get used? Yeah, it's for early identification. So it's used for early identification of sepsis. And here I have another kind of fill in the blank. If the patient is showing 2+ symptoms of SIRS, what is your action following that? Yeah, you want to start your sepsis bundle. And nowadays, that is the 1 hour bundle. Back in the day, it was a 3 and a 6 hour bundle, but they changed it to like a 1 hour bundle now, like pretty much only a 1 hour bundle, just to emphasize how important it is to act quickly. So you don't have that much time, essentially. Yes, so you want cultures before you give antibiotics because the antibiotics yes, will change what the cultures kind of let you know. Yeah, so we'll talk more about that in a little bit. But I just want to ask you guys, what are your 4 search criteria? And I have a way of splitting them off. So, but for now, just let me know we'll talk about the substance bundle in a bit, but what about your criteria? Temperature high or low? Okay. So temperature and define high or low. So respirations, and someone said heart rate. Okay. And we said WBC. Yeah, so that kind of goes with, that's how I split it off. I split it between infection and compensation. So temperature, WBCs, respiration, heart rate. And then let's get some specifics. So we have for your temperature, kind of essentially like below 96.9 Fahrenheit or above 101 Fahrenheit. Your white blood cell count, is it lactic acid? Lactic acid is actually not part of your search criteria, but you will be doing that as part of your bundle, but not for your search criteria. The search criteria will, if you get 2+, will then get you to assess for that. Yes, so WBC count either above 12 or less than 4, or a little more than 10% bands. So bands being your immature white blood cells that, especially when they're high, are a sign of impending infection. I believe Kai said, yeah, for the heart rate, more than 90, which can throw you off because abnormal is more than 100, but in this case, for the search criteria, it's above 90 for the heart rate. And then for your respirations, it's 20. So that one actually aligns with the within normal limits. So that can get a little bit confusing. But this the main gist of it is you should know the actual criteria and you should be able to know when you should start the sepsis bundle. Okay? So be able to not just know that it's respirations, heart rate, well, WBC, and temperature, but actually know the value so you can properly interpret it. Okay? So when we talk about the Q SOFA and the SOFA, you'll find that this is where it being outdated, what the information comes up a lot. So again, the stuff that's in green is stuff that's more up to par with current understanding or current guidelines, but it's not being taught necessarily. But this is, if you are wondering, this is kind of how it is. So in some places, they still use the search criteria for early. Which ones, Josh? Depends on the hospital. Technically, the guidelines kind of push the SIRS out, but a lot of hospitals still use the SIRS criteria. But in other places, the Q SOFA has replaced the SIRS criteria. So according to the Sepsis 3 guideline, which came out in 2018, the Q SOFA is currently should be technically used as the early recognition of sepsis. But again, some hospitals still use the SIRS criteria. But the same idea stands. It's 2+ on the score. Will lead you to do some sort of action. And the general idea behind the Q SOFA versus the SOFA, the Q being for quick, is that you will use your Q SOFA score to know when to initiate the sepsis bundle. Mainly, it's if you're not in the ICU. But if you are in the ICU, you will go directly into assessing the SOFA. So essentially, if you're not in the ICU, you will do a Q SOFA. If the Q SOFA is 2+, you initiate the sepsis bundle, and then you assess SOFA to know and assess severity. So maybe we need to start the sepsis bundle and transfer the patient to the ICU, or maybe we don't. So that's why you would do the SOFA after, because the SOFA is going to be the tool for organ dysfunction. But if the patient's in the ICU, then you don't use the QSOFA as much because a lot of the patients that are in critical condition can have a lot of the criteria here. So starting the sepsis bundle when they might literally not have an infection doesn't really make as much sense. So they would do a full SOFA score in the ICU to determine if they should start the sepsis bundle instead. But again, we're not being tested on that, but it's just information for you if you guys are interested in working in the ICU eventually, um, or if you've been using outside resources, outside videos that are a bit more updated and you were confused. But I do think you should know your QSOFA. So what are the three? So we have the acronym BAT, BAT. So what's the BAT and what are the values on here? Okay, so we have blood pressure. And what is the value in particular? Less than 100? Yeah. Okay, what's the A stand for? Alter level of consciousness. And the T, yeah, tachypnea. So specifically above 22. So you see where some of these values can get a little confusing. Like here we have uh, the heart rate being more than 90, even though the abnormal is above 100 for the SIRS. And then here we have tachypnea above 22 when usually it's above 20. That's considered tachypnea. So you have some weird things that get really annoying. Yeah, that's kind of the annoying thing um, about it because during the test you're kind of having to memorize it. In real life, you always have the option to look it up, and just knowing that they exist is really all you need. You just need to be able to interpret it. You don't really need to memorize it. Like a mathematician doesn't memorize formulas really, unless they're using it all the time. They just know they exist and they look it up and apply it when needed. Kind of the same thing a lot of the time. But for the test, you'll probably need to actually have these values pretty solid. So make sure you know those. Any questions so far on QSOFA and SIRS? Again, all the stuff in green here you don't need to know, but it's there for clarity. Would. So I recommend that you know search criteria, QSOFA, and here I have SOFA actually as a light blue or whatever color, cyan, which up above just means that you should know the broad idea because there's SOFA. The SOFA is actually very detailed, but and you don't need to know it super detailed. You just kind of have to know the broad idea. But I think for the test, you should know the actual QSOFA and search criteria numbers. But for the SOFA, just have a broad idea of the stuff that make up the SOFA scale. Okay. So here, the SOFA scale, we mentioned that SIRS and QSOFA are used for early recognition. The SOFA is used a lot of time for confirmation of sepsis and also to assess how severe the sepsis is. So it's considerably more detailed. But the nice thing about all three of these is that the criteria for you to know that there's something you have to do is 2+ still. So it's still 2+ for the SIRS, 2+ for the QSOFA, 2+ for the SOFA as well. So how often should the SOFA scale be repeated? Yeah, every 24 hours. So every day should be repeated to assess the patient and seeing what's happening there. So again, you don't have to hard memorize all the stuff that make it up, but I do want you guys to have that broad idea. So just what what systems are being assessed with the SOFA scale? Renal, yeah. So renal, that would be K for kidneys, C for cardiovascular, pulmonary. So your a lot of your important, kind of like your ABC so far, like your heart, your lungs, your kidneys, which is also perfusion. Yeah, bowels. B is kind of like bowels, and they call bilirubin, and bilirubin would be elevated. So now you kind of have your whole like focus assessment core. You have um your hard lungs. You have again perfusion ABCs, and then the GI part, which is part of your core assessment. The N, what does the N stand for? What else is part of your core assessment when you're doing just think about doing your head to toe neuro. So the first part of your head to toe, the neuro, and the P's a little random, but it kind of makes sense when you think about the consequences of sepsis. So we said the big complications of sepsis are um, dysrhythmias. We said DIC. We said MI, MODS, hypotension shock. So this P associates with one of them. So when you're assessing your cardio, you're assessing your kidneys, you get a lot of that shock and that MODS and your dysrhythmias in there. Your MI kind of goes with that as well. Your bowels bilirubin is kind of your shock. Your neuro goes with perfusion and shock. So one of these is missing here. The platelets, yeah, platelets. So if you look at all your possible complications, all of your assessments correlate to something in that complication. So cardiovascular, MI, dysrhythmia, MODS, shock, all pretty much encompasses most of it. Pulmonary, part of your MODS as well, and also your ABCs. Kidneys, perfusion goes with most of these as well.
All the
Um,
labs, all your
your
physical
bowels slash bilirubin, your liver, that's MODS.
objective data, and
Your neuro goes with your ABCs, and then your platelets is the only one left that goes with DIC because that's a possible complication. Again, the SOFA is there to see how um how severe it is, how many organs are being involved, and all that stuff. So I think we should know the big broad picture with this, less so than hard memorizing some of the values, because I know they did give it to you guys, and I will copy paste it as well, but I think just having the overall picture is good. Like here's kind of what was gone over in class. So cardiovascular, and they give you specific like blood pressure maps. For the most part, you can kind of logic these out. So a lot of the time in the hospital, a lot of your typical abnormal findings, like Kaylin said. Map under 65, we know that's bad. SpO2 under 90, we know that's bad. Acute mental changes, we know that that's bad. A lot of this is kind of like a basic stuff. If they have acute abdominal pain or slash distension. I think here this one's kind of pointing out absent bowel sounds can be mistaken for organ dysfunction. So having absent bowel sounds doesn't necessarily mean organ dysfunction. So it's just kind of like a little thing to note. Renal, we know from our kidney chapter, we want that urine output of at least 0.5 mLs per kilogram per hour. Preferably, we want it to be like 1 ml per kilogram per hour. Um, And then we talked about again the platelets. If it's less than 100, that's usually when you're thinking about heparin-induced thrombocytopenia or when you're thinking about an intervention being done about the platelets. And then lastly, the lactate, which is part of your bundle. We know 4 is a sign of severe sepsis. So again, you don't have to hard memorize these, but a lot of these are kind of your typical abnormal findings. And I imagine if you saw this in a multiple choice or something, you would know which ones to click. So I'm not too worried about that. So I would say focus your energy just on knowing the broad picture. Why these assessments, which is we talked about it kind of goes with the complications that we talked the organ dysfunction, it goes with the DIC, it goes with the MI, the dysrhythmias, your in general ABCs. Okay? So broad picture for SOFA. Know the actual categories for QSOFA and SIRS, but just broad picture for this. Any questions? before we move on. So one or more of those two with the SIRS equals severe sepsis. Um, yes. So based on the older guidelines, you have your search criteria. So your early detection would be search criteria 2+. They do a sepsis bundle and then look at the SOFA scale. If you have two or more search symptoms plus one or more of your SOFA, then it can be considered more severe sepsis in the patient. Yeah, severe sepsis. Yeah, directly though, they did literally say in the PowerPoint they said here's exactly what they said. Actually, I have it written down. This was right here. This is what I'm about to post. Two or more severe symptoms plus one or more of the following organ dysfunction. Patient should be in a step down unit, is what they said. But at the very least, yes, they would be on 100%, like they'd be septic and um, using your critical thinking to determine if they need to be in the ICU or anything else that needs to be done. But any muddy points on that, don't worry too much about it. I don't recall it being very heavy on semantics or on stuff like that. It's mostly on like again like per usual like on interventions and stuff, like knowing what to do, how to prioritize. Okay, any other questions? Yeah, prioritization delegation will always come back. So you might get a random question. You might get a question that's purely like prioritization that I'm sure will have ARDS, Spence, and sepsis as something that's occurring, but like the main gist of the problem is prioritization or delegation. But yeah, they start incorporating that a lot more. Pretty much. So again, if you need to review how to calculate your map, make sure you do that because you will probably have to calculate another map. Yeah. Yeah. MAP, airway, Glasgow coma scale. When you guys do the neuro, then Glasgow coma scale will come up for your final and stuff. Yeah, that's too far. Okay. Any questions so far? You guys all remember how to calculate your MAP? Yep. Kaylin says calculate this. She wants you to calculate MAP for someone with a blood pressure of 87/69.
140 to 20, so 75.
Yeah, 75. MAP of 75. Okay. Yeah, so just keep that in your brain cells. And again, sometimes the questions are weird and they don't have the calculator like right in your face. So if on the exam soft the calculator button's not there, just check on the right, I think right hand side and check on your right hand side and click the toolkit. Yeah, so you can find it. Because I remember, I think I had what before I figured that out, there was like one problem that I literally did in my head because I'm like, oh, I didn't have a calculator. Yeah. So then next thing is the septic shock assessment. So the definition of septic shock is 2+ SIR symptoms and BP and lactate changes and hypotension despite adequate fluid resuscitation. I will go down a little bit so you guys can see this was one of your pictures on your slides. And if you were wondering what the difference between sepsis and septic shock technically is, the definition is more spelled out here. So sepsis is um, sepsis versus septic shock. Septic shock in particular is when the patient has hypotension that is not fixed with fluids and they need vasopressors. So if someone's in septic shock, what unit should they be in? In the ICU. What unit's the one that can titrate vasopressors? The ICU. So it makes sense, right? Makes sense to think of it like that, in my opinion. Oh, John, no. Mods basic summers of DICU, see possible bleeding. Mods, I mean, mods is multiple organ dysfunction. You can have it just from you can have it from shock due to not enough perfusion. DIC in particular is microclots and bleeding risk. Your DIC can lead to mods though, or they can come together. Where are we at? Septic shock. Okay. So here, yeah, patient should move to ICU. Whoops. It involves changes in your blood pressure, your lactate, CRP, procalcitonin, and then this one that they don't really go over, but I think it makes sense to go over. Again, don't stress too hard about these two. Just know that it is, but you don't have to hard memorize the numbers for these. So skin. So Josh says the skin is going to be clammy. Anything else about the skin? That is true. It will be clammy. So the interesting thing about your septic shock as opposed to your hypovolemic shock, with hypovolemic shock, patients cool and clammy. With septic shock, unless they are like very late stage septic shock, they will actually be warm. So they'll have that high temp. So they'll actually be warm and clammy. Um, but can be cool and clammy at late stage shock. But usually they will be. So Kaylin's asking why would they be cool in the later stages? Shunt. Yeah. Yep. Yep. The shock position, flat with legs up to get all that blood back to the core. All right. So, like I said, you don't have to hard memorize some of these, but it kind of goes with what we were talking about. With blood pressure, what do you expect that would make sense? And it kind of goes with what we talked about with the sofa. So what is typical? Could even just think about, yeah, just think about what blood pressure scares you, like regardless, like less than 90 or MAP less than 65. Or yeah, or 40 from baseline. But there's also another key thing that we talked about with septic shock in particular. What separates septic shock from sepsis is that their blood pressure is is what? Their hypotension is what? It's kind of vague, but low despite fluids, yeah. So they need vasopressors, which is why they need to be in the ICU because those are the people that can titrate the vasopressors. Yes. So like Kaylin clarified, after you give that bolus, if they're still low, you require pressors, which is the new understanding. I believe I don't know when this was happening, but I guess the old understanding was like just keep giving them fluids, but evidence-based practice says doing that wasn't really helping and might actually have been making things worse because then they end up overloading the patient and you get like this weird state where the fluid's not going in the place you want it to go. So they're overloaded in the interstitial or your peripheral, but they are still hypotensive and need more better perfusion. So um, that's where sorry, should have unmuted then. But then what about the lactate? Yeah, above 4. And we'll talk about, oops, we'll talk about, right? Do I not have it already? Just making sure. For septic shock, it's going to be above 4. And we'll talk about other values that will also raise concerns for your lactate. But for septic shock in particular, it's above 4. CRP and procalcitonin, don't worry about it. Don't worry about it. Yes. Is that a question, Kaylin? Yeah, 4 is severe critical. Yes. So the lactate means that the higher it builds up, it's that lactic acid. Like we know when you work out, you build up lactic acid because you're having some anaerobic metabolism happening. These people, they're not perfusing well. Their body needs ATP, so their body does so by making lactate as a byproduct. So that starts to build up. So septic shock and lactate end up correlating together. But just to answer your question, Ryan, yeah, if it's above 2, you need to get another one to see the progression. Does it go back down? Does it keep going up? Yeah, 2 to 3 hours. And yeah, we'll talk about that. But like I said, don't worry about CRP, don't worry about procalcitonin. They talk about it and it's relevant, but it's not a priority. I guess you could just know it exists, but don't worry about it. Know this value and know what a normal lactate is. Know the difference between a lactate of 2 what you should do versus a lactate of 4. This kind of goes without saying the MAP less than 65 or BP less than 90 makes sense. This part you should know. But don't worry about CRP or procalcitonin. know if it's elevated that could show symptoms. Yes. If even that, it's not really as widely tested on. It's not gonna not you're not really gonna have to worry about it. Your CRP is one of your inflammatory markers, and the procalcitonin has other uses in the body, but uh, the correlation they found was that it increases um, when someone has an infection. So because the release is driven by some of the chemical hormones that are involved in inflammatory responses. So basically, they show that there's some sort of inflammation going on, and they found that they correlate with sepsis pretty well to the point that they can get measured. But your classic one is going to be mostly just your lactate and your criterias. So I think they gave you guys numbers for them. I don't recall needing to know it. So save some space in your head for other stuff. What were you ready? Oh, all right. Let's see. What? Let me see what else. So we said additional. So what else is would be good to assess with someone with septic shock? Just double check that it's not already on here. I like that. So a lot of your shock related things. So we know shock and urine output related. And again, if you go back on your sofa, again, just want you guys to know that broad topic, your kidneys are involved in there. You want to have that proper urine output. So urine output, your MAP is a good thing to titrate. Yes, generally your ABCs, your level of consciousness. Yes, the BG as in blood sugar. So blood glucose. That's another thing because we mentioned again, one of your consequences involves the release of your steroids. So you have a weaker immune system, which is definitely not helping when somebody has a active infection, but also the hyperglycemia. And they found that having a blood sugar that is too high can lead to worse outcomes. Bleeding and bruising, yes. So again, you're assessing for your complications. So bleeding and bruising, yes. So what is too high for your blood glucose? How do you want to maintain it? Basically, between 110 to 160. Anything more is considered bad, and especially 180 plus is especially attributed to higher death rates. And if the patient does have an uncontrollable blood glucose and they're septic, what could be done for them? Insulin drip. What kind of insulin is being given to the patient in an IV fashion? Yeah, regular insulin only. Okay. And the insulin drip is possible. Regular insulin only. Okay, we said bleeding, bruising because we mentioned one of our complications is DIC. Um, okay. And we're going to start to talk about your bundle and management in general. So we actually don't have too much more left before we start questions. I do think your test your test obviously is going to include both your sepsis and your ARDS vents, but I think it's a little bit heavier on ARDS and vents. Correct. Do you agree with that, Caitlin? Yeah. Yeah, but don't shrug it off. Okay. Any questions so far? Any need for clarification on your assessment and what is important? So I think of course, your blood pressure, your lactate, all of these are important. Yeah. So you guys already had your hemodynamic lectures, so being able to interpret well those values again. So like a CVP and whatnot, and like how do they like what do they mean for the person? How does that affect treatment? And speaking of that, that's also like another thing that could be considered. It's like the swan scans and stuff. Oh, it wasn't a question. I think it was just how you guys had the hemodynamics. So some of the way you can get tested would be based on interpreting your swan scans and values and using those to determine how the patient's like doing. Oh, true. Yeah. All right. There's no more questions. We'll move on to the septic shock management. So I do have this section here on the current best practice. So we talked about this already. It's the current understanding is after initial IV fluid replacement, basal pressors are given. If it's if IV fluids are inefficient, as opposed to the old way, which was just keep giving them fluids. So that's the new understanding. The 1 hour sepsis bundle is also the current thing that is done. So ever since 2018, the 1 hour bundle's been the standard as opposed to like a 3 hour or 6 hour bundle. So the idea is that all interventions should be done within the hour, or at the very least for the fluids should be started within the hour. Essentially, you want to start as soon as possible. The fluids probably want to be finished within like a 3 hour period. Although again, like here they mentioned, I believe in class she said, or in the recording she said, finish IV fluids within 6 hours. That's a bit outdated, but I don't think the semantics actually mattered. I don't remember it mattering. So the main thing, well, there's stuff to think about within it, but again, this is current understanding, but a lot of what was in the lecture is outdated. So the 6 hour bundle, and I mean, in real life, you will probably be doing the 1 hour bundle, but the 6 hour bundle, it's kind of confusing because they're both kind of part of one whole thing. It's just kind of your time frame. So I do have stuff that's in here. Yeah, exactly. So a lot of things you'll find online is going off the current understanding where everything is done in an hour, if possible. So I mean, we'll talk about it. So what's included in your 1 hour bundle? Blood cultures, okay. What else is included? And I know you already mentioned, Yeah, the broad spectrum antibiotics, you mentioned that you would take the blood cultures before the antibiotics. We're going to get lactates. We're going to do fluids. Okay, what are your prioritizations on this? So let's say we have a patient with blood pressure of 82 over 51. Okay. Is your priority to give them an IV fluid bolus, to give them take their blood cultures, to take their lactate, or to give them antibiotics? Yeah, you're gonna want to make sure they're alive because that blood culture is not gonna matter if they're dead, right? Yes. Yes, you definitely want those cultures before the antibiotics, but there's nothing that's gonna come before your ABCs. So here we have the magic marker. Boom. And also, what is the rate? I think Ryan mentioned it already, but what should the amount be? It's like an ml per kilogram number. 20 to 30. Yeah, and preferably 30 if possible. And what else do we got? Okay. What kind of fluid should it be, or does it have to be anything specific? Okay. Is there a preference for anything? For any IB fluids? NS or yeah, typically it's between NS or LR. Basically your isotonic solutions. Yeah, because you don't want to cause big fluid shifts, so isotonics. So in general, um, to increase volume, your isotonics are always going to be your start. So kind of review from fluid electrolytes, isotonics first, and then your hypertonics and hypotonics, use those to play around with the fluid shifts. But when they don't have fluids to play around with, you always go isotonic. And technically, there is a preference for lactated ringers, just because a high amount of LR is actually a little bit more balanced in terms of what's inside of it. The main reason we don't use LR for everything is because it's not compatible with a lot of stuff. But in units where you're not really giving a lot of medications like OB, they prefer LR because usually those patients that come in, they're coming in just for to give birth and not usually for other medical reasons they can have, but because for the most part they're healthy and nothing is really wrong with them other than they're giving birth. The LR is preferred. So same idea. If you if they don't have to if they don't have to be given other stuff IV that that you need NS to be compatible with, then LR is technically preferred. What's this one? And here they tell you to complete it within a 6 hour period. Uh, But again, and this is in green, so this is like modern understanding without the the class in mind. Is just try to do it as fast as possible within the hour to 3 hour period. The 6 hour period they tell you, I don't think is particularly fast enough. And you'll find again if you do outside research, outside videos that that 6 hour period is not sufficient, and your answers on those like Quizlets or whatever will align with that 1 hour bundle, completing the everything within the hour. We mentioned the blood cultures 2 times and 2x because it's aerobic versus anaerobic cultures. What's the purpose of getting two different types of cultures? What is the end goal for your antibiotic treatment? Yeah, So you want it to be, you want to make sure you find out who that is, who that pathogen be. You want to directly target it as soon as possible because over long periods of time, those broad spectrum antibiotics can actually make the infection worse because you're opening yourself up to opportunistic bacteria. So you want to do your two different types of cultures, your aerobic and anaerobic, to try to find out what exactly it is and directly target it. We mentioned lactate as well, and we did say, I think right here we talked about these already. So what do you do if the lactate is 2 plus? Yeah, you want to reassess again in, all right, kind of how many hours we do. I know we mentioned it, yeah, like 2 to 3 hours. And if lactate is 4 plus, cry, yeah, pray or cry. Yeah, it's severe sepsis. They should probably be transferred to the ICU and need a lot of help. Probably need, um, yeah, make sure you, if you didn't already start your sepsis bundle, you probably should have been started that thing, and it might correlate. Yeah, go ahead, Kaylin.
Okay, because I got buried in the mix somewhere. I was asking if anyone had ever done blood culture collection, particularly for sepsis, where it says blood culture X2, because to be frankly honest with you, on paper, I was like, oh yeah, like you do this. And then I saw it and I'm like, wait, that's how it's actually done? Um, so it's the two vials, and they're kind of chonky. I forget how many mLs are in each one. It's like a bottle. It looks like a tiny shot bottle. And one is for your anaerobic, one's for your aerobic. Um, you're gonna do the first set, so anaerobic and aerobic, you're going to do it from one site, and then a little while later, like 10, 15 minutes later, you go to another site and draw aerobic and anaerobic again, and both of those get sent out. So in total, it's four little bottles. I did not know that until I saw it, and I was like, oh, that makes sense. I just didn't think about it.
Okay. And then what they mention as being the 6 hour bundle here, again, we talked about this a few times, so I'll just kind of reveal that. So according to the lecture, it's within 6 hours. In real life, it will be definitely faster than that. But after the IV fluids, consider if they're going to need basal pressors. So that comes again from knowing what their MAP and their lactate levels are. And then these are examples of some of the medications that they might be given. And then also keep in mind what effect they have on the body. So for review, let's actually discuss them. So norepinephrine, how is that affecting the body typically? Dopamine and epinephrine. So when you're giving this as a drip, what do you expect to change? Increased blood pressure. Okay, cool. So this is going to be your first line for blood pressure management because it's going to be more targeted at that blood pressure increase. What about dopamine? Yeah, so this one's going to be increasing blood pressure and heart rate. And then the epinephrine, mostly the heart rate. So it's going to increase heart rate, can increase BP at higher doses, but for the most part, this is kind of what you got. Are you asking me, Caitlin, or the class? I mean, the epinephrine's gonna be more of the heart rate only squeeze, like the heart specific squeeze. Dopamine can do both BP and HR, and then yes, this one's levo-fed. By the way, on the NCLEX, it's only generics, just so you know. Oh, I see what you're saying. It should also increase contractility. It's one of the pump that D med. Yeah, let me double check on that because I think it also does have some sort of effect. Yeah, it can. It has a inotropic effect. Yeah. All right, and then we mentioned consider that CVP line to guide treatment, so you might have to interpret some more of that CVP, PAWP, and whatnot. SVR. I don't think SVR comes up, but yeah. Now, last thing for you guys is any additional interventions that you can consider for someone in septic shock. And I know we listed a few, but I want to see if you guys can come up with some more or restate the ones you guys already mentioned. Chaplain, that's funny. Glucose monitoring, I like that a lot. So let's say IQ checks. How often do you guys think? Yeah, ACHS. It may be on a SS. Super Saiyan. I don't know. Sliding scale. Um, true. What else did we mention? Mention treating heparin Lovenox, clotting issues with heparin or Lovenox, or stopping those therapies. I feel like did I? Let me see if I mentioned that. I feel like I did somewhere, but maybe I didn't. I guess I didn't mention it here. Thought I did. I guess not. When it comes to DIC, like the treatment for it, I guess I didn't mention it. Whatever. It's not really important for this. Fusion, source control. Yes, aseptic technique. Did you mention heparin? Yeah. So, for example, let's say patient has, let's say coagulant, like control clotting or bleeding. Let's say the patient has DIC, for example. What is typical? Do you guys know for DIC, what are some considerations for that person? Oh, I knew I posted something here. No, I meant like treatment. So mention blood products. Okay, that was for thromboembolism bleeding. Okay, what are they getting infused? Are they getting platelets? Are they getting fresh frozen plasma? Red blood cells? What do you guys think about heparin for DIC? So a heparin drip can be used for DIC if the microclots are the main problem. If the bleeding is the main problem, then platelet or fresh frozen plasma. Yeah, it's very tricky, which is why you kind of gotta, the main intervention for DIC is to pray. Um, we mentioned about repositioning already. I know one of you guys mentioned it, so I had some stuff here. For the most part, this is extra, and we did talk a lot about this already, so I'll just add it over here. This goes here, here, here. So some extra info, but your DIC panel includes your D dimer, PTINR, platelets. You should assess for bleeding, which we mentioned already. Colons and Gray Turner sign. I have some extra info, like versus platelets and fresh frozen plasma, but the patient's bleeding and their platelet count is certain. Like, it's a lot of extra info here, but if you were curious, and we already talked about the blood sugar. Yeah, exactly. So the patient might need blood. They might need, yeah, I like that. PRBC infusion. So they might need blood. They might need fresh frozen plasma. They might need platelets. They might need heparin drip. Depends a lot on what their actual status is. Are they actively bleeding? Are they not? Are they having issues with the clotting? Patient-centered care. All right. Any questions on anything thus far? Because that's actually it for my side, and then Kaylin's gonna talk to you guys about some questions. Let me know if there's any questions. If not, Kaylin, you can go ahead. Do you think you could screen share, Kaylin?
I don't have co-host.
Oh, really? Okay.
Sorry, Queen. Why, you got somewhere else to be?
I was gonna see if I could do my discussion board.
Please? I'll
Work
just
on,
tell you when to scroll down because you have questions 1 through 5 up. So just leave it there and I'll tell you when to scroll.
all right.
We'll come back to you.
I'm gonna work on my BSN, guys. All right, BRB.
That is hilarious. Josh already on it. Which of the following is not a symptom of early sepsis? So knowing your difference between early and late, because, some stuff might come up with that. Just a thought. Determining how busy your shift is going to be. Oh, I just realized more people joined the Zoom. When I looked at it last, it said like 12. I just finished a whole can of Alani. Delicious.
Wait, one of the big ones?
Yeah,
Did you have one in the morning too? Or was that yesterday?
it was yesterday. Don't scare me like that. I was like genuinely like, oh my gosh. Okay. So yeah, you guys all got that. So an early septic shock, you have that vasodilation, you have that rush of blood, causing flushing and warm and clammy skin. So when you see it become cool, we have a problem because at that point they're starting to shunt and all the blood is being pushed to the vital organs to sustain themselves. Their body don't care about their legs anymore. They care about the heart, the brain, kidneys more. So yeah, cool clammy skin is a sign that you can't go on your lunch break. Cool beans. Yeah, number 2, priority intervention when treating a septic patient. Here are your vital signs: heart rate of 110, blood pressure 89/43. Ooh. Respiratory rate 28, oxygen 96%, 2 liters on nasal cannula. Oh wait, no, there's still some left in my can. I don't know if you guys could hear it. Like a smidge left. Not anymore. Yeah, cool beans, guys. So thank you for nobody choosing anything other than something to do with your blood pressure. Yeah, if the patient is going to be crashing in front of you, I don't want to, get cultures and then come back in the room and be like, Mr. Johnson, I got your blood culture. Ooh, Mr. Johnson's gone. So maintaining your MAP above at least 65 is critical for this patient. Especially we need to determine if this patient is responsive to fluid resuscitation, because if not, then we're going into pressors. Blood cultures can wait, because again, if my patient's dead, I can't really do anything from there. And the antibiotic definitely has to wait until the cultures are done. Cool beans. Number 3, administering how many milliliters per kilo crystalloid fluids for lactate of what? Oh, you didn't have to move yet, Diego. You're good.
Just thinking ahead, you know?
Get back to your bachelor's degree work. It's fine. You're
No,
fine.
my discussion board, my
Which one are you
reply.
doing?
I think it's on ethics.
Wonderful.
Yeah, very fun. Da, da, da.
I was saying this the other day and I thought it was kind of funny. Well, it's not I don't know if it's funny. It's kind of messed up. That that the cost of the 8-week session we're doing, which is 3 classes, is $2,000. Because university is expensive. Community college is more affordable, but Cal States are expensive. University is expensive. And it is like kind of high key the most meme classes I've ever taken in my life.
Yeah,
Like what I wrote it, one of the classes they have us watch like a little movie every week and you write, a discussion board on it. It's all discussion boards. And I'm like, dang, it's expensive discussion boards. Okay. That's too much on that. But yeah, so uh prefer the range that you're given in class is 20 to 30 milliliters, but you want to shoot for the higher end of that because I don't want to underdo it and end up with, a patient that's not getting enough fluids and blood pressure is not being maintained. So you're gonna want to shoot for that 30 milliliters for a lactate over 4, because at that point it's showing major hypoperfusion and tissue hypoxia. Josh, already on it. Thank you. You're a nurse caring for a patient in septic shock. Your initial vital signs, you guys can read it. You give a bolus, that bolus we talked about earlier. You get new vital signs, and then what's your next step? Does everyone agree with pressors? Yeah, I was like, yeah, I'm pretty sure we agree with that. Yeah, so pressors at that point, because we saw that we gave that bolus and that blood pressure said, I'm not really gonna fix it. Um, yeah, they're hot. So, we talk about the patient needs pressors, but what kind of pressor do you think would actually be best for this patient and why? Okay, so I have a levofed. What about dopamine or epinephrine? Yeah, I was like, I'm pretty sure that's what you meant, Josh. Anyone want to give epi? Epi-depi? No, and not yet. Epi later if not controlled. Cool beans, guys. Um, And yeah, the dopamine not gonna help as much either, or if necrosis sets in. Yeah. So why bring up necrosis? What is this about necrosis? Watch the feet. Vivofed is a major constrictor. Darn right it is. So its main effect is a vasoconstrictor. It has very minimal effect on your heart rate, if any. So because it's such a powerful constrictor, you need to monitor basically your CMS, circulation, movement, and sensation of your extremities. Not just to the feet, but to your hands as well, any of your extremities, because, at any point you could shunt too far and then hands gone or toes gone. So dusky color, cooler skin, pulselessness, etc. Yeah, you guys got that one. Was there any other? I think that was the bulk of it for that. Oh, and then for epinephrine on this one, you would want to be kind of careful. I have a heart rate that's pretty up there already. So it might not be like epinephrine is definitely, we're not doing it first line, but I need to be super careful if it does get introduced because that heart rate is very high already and it's just going to make it go higher. Okay, and then number 5, what lactate level drawn prior to hydration requires a redraw after hydration? Everyone agrees with over 2? What about anyone over? Do I have another number there? No, I don't. Oh, I didn't put over 4. Oh, I missed an opportunity. Lame. I should have put over 4. Okay, well, yeah. So lactate over 2, you need a redraw 2 to 3 hours after, and then like after you do your fluid resuscitation, because that's going to tell you how much tissue hypoxia and hypoperfusion is going on. It's going to guide your treatment a bit more. Over 4 is extremely critical, and we know what's going on already, especially if we got that blood pressure from the question above, but it is what it is. But yeah, so redraw over 2. Number 6, after sepsis or septic shock has been recognized, within how many hours is it recommended to administer IV antimicrobials? Microbials. Anyone want to go for 2 or 3 hours? Okay, good. Because that's part of your 1-hour bundle. So knowing your 1-hour bundle includes that. You need the blood cultures beforehand. Those 2 sets, 15 minutes apart. So those 4 vials, I forget how many mLs it actually, like you actually collect in each one, but it's a big bottle. It's a bigger bottle than I thought it would be. So finishing that, trying to finish that and get that complete within the hour. And then technically your IV fluid should be started within the first hour and then completed within a few hours. So in my head, it's part of the 1-hour bundle too. Pretty much everything is in my head. But yeah. So then on to number 7. Which of the following findings indicate possibility of sepsis? Select all that apply. Okay, cool beans, guys. So it's going to be B, D, E, and F. If I remember correctly, respiratory alkalosis is related to sepsis, so they would have an increased respiratory. Yeah. Um, that's part of the what's it called? The SIRS and the Q-SOFA. So with your sepsis, you have that whole corticosteroid release thing. You got that. What's the word for it? I'm just gonna call it steroid. You have the steroid thing going on, and that can cause, stress response. So you end up with hyperglycemia without the person having diabetes. And that especially needs to be controlled because there's a couple of different complications that come of that. First and foremost, it's high blood sugar. I mean, that's not good in the first place. Second and foremost, it could mess with our healing as well. Third and foremost, wherever the infection is, it's just gonna make it worse. Like, I'm like sugar for real. Like, I love I know, I'm like bacteria for real. There we go. Because I like sugar. I like a lot of sugar. So the bacteria like to eat all the sugar. The more sugar you supply it, the more it eats, the more it grows. So definitely will worsen and hasten your infection. So hyperglycemia without diabetes, white blood cell count of 14,000, because that's your leukocytosis, or watching for greater than 10% of bands make it, respiratory rate of over 28 because we're compensating, and a heart rate over 103, as well for compensatory mechanisms. And then leading into number 8, SIRS criteria includes what? Because it get confusing real quick for me. I've missed so many opportunities to do so much other stuff here. It's been a busy week. Sorry, guys. That's the funny part. I was looking at the word and I was like, I don't even know. A painful aching in the foot. No idea. Never heard of her before.
Oh, that
What?
makes sense. Like algia is in pain, like tarsal,
Like
like your
metatarsals?
metatarsals. Yeah.
I didn't think about it. Yeah. So yeah, this one's pretty obvious, right? So your temperature, tachycardia, tachypnea. What is missing from this SIRS criteria? Is there anything else that's missing? Yeah, and the bands too, technically. Anything else? Okay, good. Don't question yourself because yeah, I think a lot of people get confused and think that like the blood pressure is part of SIRS criteria. I definitely got confused and kept thinking that blood pressure was part of that criteria. I don't know if any of you fall into that category. Yeah, I was like, Kai, don't question yourself. Y'all gotta be, yeah. It's the most mistaken vital sign for sepsis initially. That is true. But yeah, that comes in later with your SOFAs when you're getting into your septic shock stuff. But yeah, with the white blood cells, also looking for those bands as well. So greater than 10% bands would also meet SIRS criteria in that case. But yeah, don't question yourselves. You guys got it right. Okay, number 9, a post-op client admitted to the ICU with septic shock. Which nursing action should the nurse delegate to the experienced nursing assistant? Because delegation will never go away from you. It's your water in your check. Random question for you guys. For those of you that went to the ICU at locations other than PIH, is there CNAs on the floor there? Okay, PIH didn't have any. That's why I was like, oh, I saw this question online. I was like, oh, that's kind of ironic because I didn't see nobody, sadly. Hold on real quick. Apparently, I just got mail from C's Candies. You get 25% savings for National Nurses Week,
Oh, what?
May 6th to May 12th. So I'm gonna go to C's Candy and buy up the entire store. I'm gonna buy the entire earth.
Do I have to like show proof of your nursing license or something?
That would be so weird. No, just show up in scrubs. It's fine. Baller. But yeah, so not the earth. But yeah, with your patients in septic shock, I mean, this is a highly critical condition right here, especially if we're dealing with that septic shock that's unresponsive to fluid administration and requires pressors. So at that point, when you have patients with increased criticality, a lot of times, like even just what we think is more basic assessments are thought to be needing more. So like vital signs every 15 minutes, while that's typically fine for CNAs to do on floors, if we have a patient that blood pressure is very quickly changing and we're titrating medications, it needs to be interpreted pretty quickly. So it would be preferred for nurse to do it. Checking oxygen saturation, same thing, because your O2 sat can drop out very quickly with this patient as well. And we all know as well that assessments are the only, or nurses are the only ones who do assessments in NCLEX world. In NCLEX world. I don't think there's anything else there. Okay. Number 10, so you have levo has been prescribed for a patient with hypotension. Which patient data indicates that the nurse should consult with the healthcare provider before starting norepinephrine. I'm gonna put an S right here. That's gonna bug me. I'm not gonna lie, I was kind of mean to you guys on this one. High key, I was mean. Um, it didn't specify if this was for someone with sepsis or septic shock. I mean, it's implied. Um, but the thing to note here is your CVP, which you're going to have different values at different places. I've seen where they've considered one to be fine, but it's on the lower half of normal. They are dry, and of course this is not always black and white as well. Your CVP has other meanings in different settings. But in general, what you're taught here is that your CVP is a fluid volume indicator. So if you have it on the lower side, patient's drier. If it's higher, then it's over, what's the word? Over fluids. You know what I'm trying to say. They're wet patients.
Overloaded?
Overloaded. Thank you. Oh my God. Yeah, Theo. Thanks, Kai. Yeah. And sinus tach, don't really care too much about that, as horrible as that sounds. I'm looking at the hypotension. It's probably a compensatory mechanism, and my levo does not have a very large effect on heart rate. If this said epinephrine, I would maybe reconsider a bit, especially if they were already on and I'm titrating. Definitely reconsider how I would titrate those meds. Low dose dopamine, I don't really care. I mean, just sure, mess it up, go for it. And has had no urinary output since admitted. I mean, depending on how bad their hypotension is, and according to the situation, apparently patient's dry. That could be reasons for why they haven't had a urinary output since they were admitted. And it's not inherently a contraindication for norepinephrine administration. But yeah, I was a little mean on that one. I'm sorry. Forgive me. But yeah, things to consider definitely when you're dealing with what meds you're gonna want for pressors, what combinations go together, when you titrate up, when you titrate down, etc. So yeah, that is all that I have for you guys, though. It's been a long week. I could have done a little better with the answer choices, but these were a lot of talking points today.